the moderating the program. My name is Musanget, working at the School of Public Health and then also an adjunct lecturer with the University of the Gambia. So on the introduction, we have conducted this our third webinar series, and we're hoping and then more of it coming. And then every week we have it on Fridays, 4 o'clock, and it's in English language. And then currently we have opened our YouTube channel called the Epi Hour series. When you get to YouTube, you can see, type in Epi Hour series and you'll be able to see our channel. And then all our videos, recordings are posted on our YouTube channel. So please log into YouTube and then subscribe to our channel. And then today's discussion will be focused on flattening the COVID-19 curve in Sub-Saharan Africa in an epidemiological perspective. That's why today you'll be amazed that we have people who are well grounded in epidemiology, and they're here to share their experience and tell us the modalities in which we can make sure we have flattened the curve of COVID-19 in the Sub-Saharan Africa. So on our next webinar, which is next week, we'll focus on quarantine and case management of COVID-19 in the Gambia, which we will have specialized people to come on board to make sure that they tell us the quarantine system in the Gambia and then how best we are doing in our case management system. So in the future too, this program is actually weekly and it is always on Friday, same time, 4 o'clock. And then please subscribe to our YouTube channel for the video recordings. And then please, to all of you, can you please drop in your email addresses on the chat box so that we can send you this evaluation form for our subsequent session, so you can give us your feedbacks on ways and means of what, making sure that this webinar is actually improved and then yield its and then please pass this webinar advert to any friend, any colleague within and outside the Gambia, all over the world. It's not actually only stopping here, but we're making sure that it's one of the best channels, it's one of the best series we can see in the entire world. So we would love you to make sure that you let your other colleagues in the diaspora get connected to this webinar series. So this is our team. We have a team of 4. Mr. Amadou Barrow, who is from the University of the Gambia, Mr. Seo Marsila from the School of Public Health Gambia College, Babu Karlum from the Gambia Tourism Board, and Mr. Musanget from the School of Public Health Gambia College. So one of our presenters is Mr. Yakub Singate. Yakub Singate is a public health professional working with the Ministry of Health. He has worked in different areas from the grassroots level down to the central level, and then also had back international appointment with WHO on the Stop Polio campaign in Africa, where he gathered a lot of experience and came back to see how best to give his quota back to this country. And then Yakub has shown great interest and then great strength in epidemiology. Today we have him. Yakub has backed a high national diploma in environmental health at the School of Public Health Gambia College, Bachelor's of Science of Public and Environmental Health at the University of the Gambia, and then a Master's of Science in Epidemiology. Currently, Yakub works with the Epidemic and Disease Control Union of the Gambia under the Ministry of Health and Social Welfare. And our second presenter is Dr. Greg Okobo. Dr. Greg is a medical doctor by profession. He backed his MBBS at the University of Benin in Benin City, Edo State, Nigeria, a Master's of Public Health, General Public Health at the University of Benin, the Department of Community Health, and a Master's of Science in Biostatistics and Epidemiology at the Cyprus University of Technology in association with the Harvard School of Public Health. Dr. Greg, beside his academic work, he is still a research fellow at the Harvard School of Public Health, Boston, and currently pursuing his PhD at Tampere University, Finland, in epidemiology. Dr. Greg currently works as the consultant epidemiologist to the Incident Management Committee of Edo State COVID-19 and also some other states too in Nigeria. And then he is actually the head of the Special Statistics Unit of the University of Benin Teaching Hospital and the deputy coordinator of Benin Cancer Registry. And then he has an institute, being a co-founder, the Zigma Data Intelligence Institute in Nigeria, in Edo State, Benin. So these are the two great presenters we have today, Dr. Greg and then Mr. Jakub Singate. And then the discussion today will be on COVID-19 in Sub-Saharan Africa, epidemiological perspective. On that note, I would like to invite Dr. Greg to start his presentation. Dr. Greg, welcome on board.
Thank you very much, Musa. Good evening to everybody listening. I am very delighted to be here today to be part of the Epi Hour. And the sound of Epi Hour sounds like happy hour. So I hope this will be a happy time for all of us. With the permission of everyone, I would like to share my screen so that we can all be part of the presentation. So today, as introduced by Musa, I'm going to be talking about COVID-19 curve in Sub-Saharan Africa. And we're going to, as much as possible, look at the epidemiological perspective. So this is going to be a very detailed look at COVID-19, with special reference to Africa and African countries, especially Sub-Saharan Africa. And I'm going to, as much as possible, bring on board my wealth of experience as the epidemiological consultant to the incident team in Edo State, Nigeria, with respect to COVID-19. So I hope everybody can see my slide. Just indicate in the chat so that I know I'm not talking to myself.
Yes, your slide is showing.
Okay, thank you. I'll just move on and I'll be as fast as I can. I'm going to use this content to look at today's discussion. And as you can see, it's a mix of both epidemiology and socioeconomic realities. How do we marry both with respect to COVID-19? So the question is, what is COVID-19? This may sound basic, but I think it will not be complete if we don't really look at what is it. So COVID-19 is a also referred to as corona virus, is a novel virus, SARS-CoV-2, which belongs to the coronavirus family of viruses. Now we know as at that it originated from Wuhan in China. On the 11th of March 2020, the WHO characterized the spread of COVID-19 as a pandemic, and it called for countries and governments to take urgent and aggressive action. We are going to dwell more on this particular statement, and we'll see how it plays into the epidemiology of the disease. And this is it here. And if you take a good look at this timeline, I've tried to put it up so that we can have a following as to how the epidemiology has, and all the nuances and all the drawbacks that can take place in the course of unraveling the epidemiology of a new pathogen. If you look down, let's start from the bottom of this table so that you can follow. If you look down here, on the 31st of December 2019, WHO says it has been alerted to a cluster of cases of pneumonia of unknown cause in Wuhan, China. This is the first reported beginning of COVID-19. However, by January 7th, WHO finds out that the new virus is a new strain, not known, not seen in the world before now. However, the source was unknown, and even till now, the source is still unknown, even though the pangolin animal is still being suspected. As we go down, you'll see the picture of the interesting animal. In January 9th, the first death was recorded. However, both WHO and China were in denial of the human-to-human transmission. They said it's unlikely. And this is very key in the epidemiology, this denial here. But as of January 12th, China shares the genetic sequence But by 13th, the first case was reported outside of China. The importance of this sharing of genetic sequence is for issues of vaccine. Knowing the sequence, we can actually begin to work on a vaccine. By January 20th, then they have come to the reality that human-to-human transmission is possible, and they've confirmed it. But that is almost a month after the first case was reported. So that delay is one of the issues that has led to this huge burden we are facing today. But by January 23rd, WHO has declared it only in China as an emergency, only in China. However, by January 27, WHO has said that they made an error in the risk assessment of the virus. Owing up an error is also key in epidemiological pattern. And then by January 30th, WHO declared the coronavirus epidemic as a pandemic. And it also declared it as a public emergency of international concern. Now, this term is public health emergency of national concern. And then if you also take a look, that was the same time that the name began to evolve also. As at that time, it was referred to as 2019 nCoV acute respiratory disease. But now it's referred to as COVID-19. So what is PHEIC? According to the International Health Regulation, a public health emergency of international concern is defined as an extraordinary event, which is determined to constitute a public health risk to other states through the international spread of disease and to potentially require a coordinated international response. This definition implies a situation that is serious, sudden, unusual, or unexpected, carries implication for public health beyond the affected state or national border, and may require immediate international action. You will agree with me that the COVID-19 meets all these criteria. So the WHO was actually forced to declare it a public health emergency of international concern. Let's look at Africa. The first case of COVID-19 in Sub-Saharan Africa was confirmed. Please take note, this is Sub-Saharan Africa, because the first case was not actually confirmed on the 27th. It was confirmed earlier than this in North Africa, which is not part of Sub-Saharan Africa. But the first case in Sub-Saharan Africa was confirmed on the 27th of February 2020 in Nigeria. Surprisingly, you know, Nigeria is actually makes up more than about 20% of the African population and 50% of the West African population. So this case was actually the third case in Africa, but the first case in Sub-Saharan Africa. And since then, the number of COVID-19 cases has increased steadily. As of today, 173,455 cases have been confirmed in Africa. This make up a meager 2.6% of the global confirmed case. That tells a lot. And then sadly, we have recorded almost 5,000 deaths, and 57 African countries and regions have been affected. The first confirmed case, however, was an imported case. It was an Italian that came into Nigeria for construction work. Still using Nigeria closely, the case fatality rate as at today in Nigeria is about 3%, which simply means that of 100 people confirmed cases, 3 dies. Most affected people are in the 31 to 40 years age group. Men somehow seems to be disproportionately affected, and already we are witnessing community transmission. Only 2% is now attributed to imported transmission. Let's look at the situation analysis globally. This is the global picture as at today, 5th June. we have over 6.7 million coronavirus cases globally, with almost 400,000 deaths, and about 3 million have recovered. If we focus those active cases currently, we still have about 3 million currently active cases, of which 98% are mild, and only 2% are serious or critical case. So that tells also a lot about the epidemiology and also the management of the COVID-19 case. Just 2% are severe or critical. This is also a global picture on the cumulative number of cases. And if you take a very good look, what strikes you immediately is that of about the 7 top countries, none is actually African country. The number 1 country here now is the United States of America, and is increasing cumulatively in a steady direction upwards, followed by Spain, Italy, and so on. So this is the global picture. And by the share of cases, you can still see that America is almost 28.6% of the global burden. Let's look at Africa. I decided to take a snapshot of the 10 top countries in Africa by the number of confirmed cases. The number 1 here is South Africa, 2 is Egypt, and 3 Nigeria, followed by Algeria, Ghana, and so on. Okay? And if you take a look at the total case, I've already explained that, almost more than 173,000. Okay? However, my focus here, if you want us to look at, is in the number of cases tested, the number of tests done by 1 million population. South Africa is still well ahead. Nigeria is down there, as well as Sudan is down there. So these are the picture when you look at Africa in terms of the top 10 countries with the highest number of confirmed cases. Let's look at the bottom picture. This is the bottom picture. 57 countries, like I said earlier, are affected. And the least country affected by number of confirmed cases in Africa is Lesotho, followed by the Western Sahara. This is where Gambia is. Gambia is 53 out of 57, 26 cases, only 1 death. I think at this point, let's dive in a little bit into the epidemiology of COVID-19 and see exactly what we are dealing with. And I'm going to use this epidemiologic triad to look at the COVID-19. And if you take a look, you'll notice that we are going to look at the agent, in this case, which is the SARS-CoV-2. We'll look at the hosts, cause, which is humans. And then we'll look at the environment and how they all play their role in the disease. So let's take, for instance, take the first one, agent. Now, this particular pathogen, like I said, is a virus. It belongs to there are 4 the COVID genera, or 4 genera of the COVID family. And the subfamily is coronavirinae. 7 coronaviruses infect humans, 7. And they belong to 2 of that 4 family. Remember, there are 4 family, which are the Alpha family, Gamma family, Delta family, and Beta family. But only 2, Alpha and Beta, affect man. And of that 2 family, the SARS-CoV-2 belongs to the Beta coronaviruses, this Beta family here. This is where you have the SARS-CoV-2. This slide was prepared by the Finnish Institute of Health in Finland here. Let's look at the structure. The coronavirus is actually an enveloped virus, It's a single-stranded RNA virus. And look at how small it is, 0.12 micrometer. This is why you see there is a lot of issues about the use of face mask and so on, if it can protect from the virus, because the pores in face mask is bigger than 0.12. So the virus can actually enter through the pores. So it's a very, very, very small virus. It has four structural protein, but the most important one is the S protein. And if you look at the shape here, this particular radiating spikes here is the S protein. And why is it important? Because that's the one it's used to bind to our cells. So there are other proteins, the EM and N. With respect to the hosts, let's move a little bit faster. The clinical picture is a little bit understood now, okay? And most cases are actually mild or asymptomatic, as we have shown from the data. Then occasionally you have serious respiratory infections, which may occur especially in those who are in the risk groups. And who are those? We are talking about those who are immunocompromised from whatever reason, people with cardiopulmonary illness, the elderly people, and young people as well. Then the reservoir of infection, I want to focus, this is the pangolin. Pangolin is, we are still querying it. Nobody still knows the source as of today. But the pangolin animal, which is this animal here at the center, has been implicated as the source or the reservoir of infection of this coronavirus. I placed, these other ones are important for us to also take a look at, the SARS-CoV-1, as well as the Middle Eastern Respiratory Virus 2, which is the reservoir is camels. This caused an earlier pandemic as well as this, but this is new and we are still querying the source. But the pangolin has been implicated as the source. That this is the guy that transmitted it to humans. Now let's look at the environment. With respect to environment, we are going to focus a little bit on coronavirus generally, and we'll see how we can narrow down to SARS-CoV-2. The mode of transmission, of course, animal to human is still being queried from pangolin in the Wuhan market in China, but human to human, of course, has been established. The incubation period actually for SARS-CoV-2, although currently is 2 to 14, but the peak period is, on average, the median is 5 to 6 days. But we have, if you look at this diagram here, it's actually from 2 to 14 days now. There can be a period of asymptomaticness from 2 to 14 days. And also that period has been implicated as being part of the infectious period. And of course, I believe we all know that there's a difference between the incubation period and the infectiousness period. They speak to two different things entirely. Incubation period speaks to the disease, infectiousness period speaks to transmission. Now, the route of transmission is fomites, it can be airborne, although it's still being queried. What is being said now is actually air droplets, not really airborne. Fecal to oral has also been implicated in some instances. Then nosocomial spread is a big driver for this current SARS-CoV-2. So you notice that most health workers now are being infected, and the first doctor in China that made the observation of this new disease actually died of it. How do we actually mount control and prevention towards this? It still follows this epidemiologic triad of agent, hosts, and environment. I don't want to go too deep into it, but this is the focus here. You should focus, so to control between host and environment, education, change activity pattern, and then quarantine. To break the link between host and agent, protect, educate, alter exposure. To break the link between agents also and the environment this way, you remove the breeding grounds and improve sanitation. So whatever strategy we are bringing on board, we already know the epidemiology. and we know what intervention we are supposed to actually deploy. So whatever policy, strategy, response that the world is bringing up today is actually, the backbone is this particular triad here, this particular triad. So let's